Part of the care unit, and I would call him a force in changing the way we think about shared decision making. And he's going to be presenting to you some very novel work that he's been working on about the different purposes of shared decision making and how that drives the type of shared decision making that we actually need to think about doing in our practices and with our patients. So it's my pleasure to welcome Dr. Ian Hargraves to the stage to kick off our Care That Fits event.
Good morning, everybody, and thank you for joining us here on what we would consider a beautiful fall morning here in Rochester, Minnesota. I see glimpses of snow coming this weekend, but for now I'm going to enjoy the sunshine and the warm weather and have I hope, a very fine time together here. Thank you, Casey, for the introduction. Again, my name is Ian Hargraves. I'm a designer and shared decision-making researcher working in the care unit. I am a relative newcomer to healthcare and the work that we do here. As I say, my background is in design. Before that, I was in building high-boarding, so I'm something of an odd fish in this room, although after 5 years, So today what I want to do is talk a little bit about the idea of care that fits, complement it with the idea of care that's fit to care. And we'll see if we can expand that theme as we go along. And along the way, I'm going to segue, as Casey said, into the idea of shared decision making and talking a little bit through how we're changing our thinking about shared decision making, what it is and what its role in healthcare might be. So as I say, I'm a relative newcomer to the field of healthcare, and from the outside, when I first approached it, I was really blown away by the scale of the healthcare enterprise. PubMed indexes 30,000 medical journals. The index also contains 29 million articles. Clinicians in this country, on average, spend 40 years in training in order to become physicians. And $3.8 trillion is spent in this country every year on caring for health. And yet, the huge scale of the healthcare enterprise in this country, healthcare has one very small problem: how to care for Maria Luisa. Now, Maria Luisa, at the time this photo was taken, was 87 years old. Most of her life she lived in Peru, but currently she lives in Alaska with her son, who takes care of her. Maria Luisa has hypertension, and for the last 5 years she's organized her life around going to hemodialysis 3 times a week. In addition to living in a part of the world that doesn't speak Spanish, or eat Peruvian food, Maria Luisa has been told by her clinicians that she needs to follow a diet that's low in sodium, potassium, phosphorus, protein, and water. And sometimes when she's unable to follow this diet, she finds herself in the emergency department. Now, Maria Luisa has no shortage of care. Her kitchen, as we see it here, is replete with it. She finds herself in the emergency department. She speaks to a primary care clinician regularly. She goes to dialysis 3 times a week. She has no shortage of care. But we have to ask the question, does Maria Luisa has care that's fit to care for her in this situation? She has all this stuff in her life, but is it actually helping her? So 2 of the themes that we're going to talk about, I believe, in this conference is how would we think about care that fits Maria Luisa's life and actually be made to work in her life? And how do we think about forming care that's actually fit to serve Maria Louisa? So I'm going to pick up this idea of fit for a little minute and think about, well, what is fit? What does it mean for care to fit Maria Louisa? Well, one way of thinking about care that fits is all the care that we can fit on the back of our patients. And this is a illustration that really depicts in some ways the way that healthcare is conceptualized in large part currently. It's a picture of as if care was something that was warehoused within care facilities, taken off shelves and delivered by delivery agents for providers, and then applied to the patients. An industrial model of healthcare is what we talk about, and maybe the patient revolution. But what we're seeing here in the picture is that being a relationship between the workload we're piling on our patients and asking them to undertake, and the patient's capacity to bear that workload going forward. It doesn't fit when the capacity doesn't meet the workload. And our colleagues in Paris have helped map out some of the burdens, some of the workload that contributes to this imbalance in care that doesn't fit. The capacity is one element of this, but there's other elements as well. Preferences, needs, and values, which are the cornerstone of descriptions of patient-centered care. So when we think about care that fits, we're also fitting Maria Louisa's preferences into the care program. So, for instance, Maria Louisa comes from Peru. Peruvians, as you may have discovered last night, are big on potatoes. And the image on the left is potatoes as they are found in Peru. Images on the right are potatoes that they are found in our healthcare system. It's a pretty sad state of affairs, and obviously Maria Louisa prefers. So in care that fits, we need to be thinking about fitting the preferences of Maria Louisa as well. But there's another thing that we need to fit, and this one is very oddly undescribed, or not so much undescribed, but doesn't come to the fore in our vocabulary when we talk about patient care and the idea of care that fits in graceful setting shared decision. And that's fit of care to the patient's problems, their experience, and their suffering, which to my mind is the core reason for medicine to exist in the first place, or healthcare institutions like this to operate. Now, obviously, problems, experience, and suffering aren't depicted in our accounts of patient-centered care. We turn them to ideas of preferences, needs, and values. But they're very different concepts. And I'm going to argue that we need to pay a lot of attention to caring for the problems of patients beyond, say, their preferences or capacity. And so a fourth element of care is really care that's around the idea of the humanity of the people that we serve. This is an image of Maria Louisa taken the day before she died, back home in Peru, enjoying some of her favorite food with her close friends and family. This here is all about who Maria Louisa as a person, her humanity, and how we value that in our relationship with care. Now, this question of humanity isn't solely a possession of Maria Louisa by herself. It extends to all who are involved in caring for and loving Maria Louisa, including our clinicians. We shouldn't lose sight of the fact that our clinicians' humanity is a very important part of this, just as our clinicians' capacities their needs, their values, their problems, and their experience, all an important part of the idea of care ethics as well. So we talked a little bit about fit. I want to talk about fitting, because that in large part is the business of healthcare day in and day out. How do we think about fitting what we're able to offer into the lives of the patients that we care for? And I'm going to pick it up again through this theme of problems. How, and ask the question, how do we go about fitting care to the problems of people? To begin, maybe we should think about, well, what's not a problem? And I'm going to argue that all of these things, diagnosis, prognosis, problemless, complexity, and need, none of them are in themselves problems. Need, for example, is close to the idea of a problem, but a need is actually a solution rather than a problem. To say a patient needs a blood transfusion, that's a solution. It's not a problem in and of itself. When we're talking about problems, we're talking about experience. Things that people actually live. I live with a threat of heart disease. I facing cancer. All these things. I'm living with multiple chronic conditions. These are things that happen in my life, in my experience. They don't happen on my problem list. They're not simply the complexity of the environment I live in. They are things that I live, feel, and breathe. So when we think about dealing with problems, there's two questions, given the sort of murkiness in which many non-technical problems arise in the context of care. The first of these two interrelated questions is, what is the situation that demands care? And accompanying that is the question, what is the care that the situation demands? Now, these two questions are interrelated in that the situation that demands care also includes our ability to care for it. So the situation of infectious diseases 300 years ago is a very different situation than what it is now, simply because our capacity to care has changed. And similarly, oftentimes we find out what care the situation demands is by trying to apply it to the situations there if it actually works in practice. And so in order to work through this loop and come to some sort of resolution, there's a number of questions that we need to address. The first very basic one is there a problem? Is there something wrong at all? And sometimes it's quite clear that there's a problem. Other times it can be very unclear as to what, if anything, is going on that requires attention. The second question is, well, what is the problem? We think there's something there. Matter of discernment, and accompanying that is the question, well, what's it possible to do in response to this forming understanding of what the problem is? The third part of it is the question of method, which is really how do we go about judging or characterizing the problem. We're going to characterize it through labs, we're going to characterize it through PhD-9s, we're going to characterize it through a process of talking with our patients, getting a sense of what's going on in their lives. And similarly, this question of judging or evaluating flows right through into the question of action. On what basis are we going to judge whether this action we're contemplating makes sense? We're going to judge it in part on issues of cost, which Dr. Breeder will be talking with us further about at some point. We're going to judge it in terms of effectiveness. We're going to judge it in terms of practicalities. And then the lingering question behind all of this is, what's our basis for making this judgment? What are our principles that allow us to say that this judgment is worthwhile? Key principles of autonomy, for example. It could be principles of effectiveness, it could be principles of justice, does actually already do justice to the situation. There's a range of them. And so when we think about looking at problems, two interrelated questions, what's the situation that requires us to do something? It's not the entirety of the world, it's just what's the situation that actually requires attention, and what's the situation, what's the care of that situation environment. And within it, there's work of understanding the problem and coming up with hypotheses, is evaluating them, and at the same time thinking about questions, why does this matter? And so some of the tools that we developed had aspects that function in these different parts of the problem resolution spectrum. So the My Life, My Healthcare tool, which Casey will be talking more with us about, is designed very much to work around the question, is there actually a problem? So in care for both multiple chronic conditions, when they come into a clinic, sometimes it can be hard to figure out what it is that we should be talking about. And so this is an intervention to try to uncover, is there actually something here that we need to focus on? The statin choice decision aid, which is used many times around the world, day in and day out, a large part of what its function is to discern the nature of the problem. And it begins by giving us an initial formulation, which is, over the next 10 years, if we look at people like you, we would expect 21 of those people to have a heart attack. Characterization of the problem. And then it goes to talk a little bit about, well, what might we be able to do about it. Our diabetes cards, a large part of the work that they do is they provide methods for judging plans of care. So we're going to judge it on the basis of, in this case, things like weight change, health, and testing our sugars. These are ways of evaluating potential problems. Plans of care. Now we're just beginning to move a little into this idea of how we let principles inform our decision making. So this is a prototype of a conversation aid intended to facilitate care planning conversations for people with late stage chronic kidney disease, moving into end stage kidney disease, and beginning to think about what sort of paths we want to follow as we go down this road. So, and the point of this whole process is really to act. And we want to act in a way that makes intellectual, practical, and emotional sense. So intellectually, this means that it's consistent with evidence-based practice. There's a sound medical logic for what we're going to do. Practical means it can be implemented and sustained in the patient's life. It actually has a shot of working. And emotionally means that it addresses, supports, and advances the emotional experience of illness treatment. Look a little bit about the process of fitting. Here this question of, is it fit for purpose? And I'm really going to pick this up through the theme of shared decision making. For two reasons. One, we think that if shared decision making is done right, then we have a good chance of being able to care that is actually fit for purpose, fit to serve the needs of the patient of whom decisions are being made. And the second reason is that we're not entirely sure that shared decision making as it's thought currently is in itself fit for purpose, whether it really does the job that clinicians and patients need it to do. Well, before I go there, I should just point out in introducing shared decision making that there's many descriptions of it, mostly that they focus around issues of involving patients, making decisions by telling them about options and supporting them in the decision-making process. It's been described as the pinnacle of patient-centered care. But I think we need to step back and ask this very simple question, which is, what is the problem to which shared decision-making is the solution? Given that it's been promoted in many venues, in this country it's becoming a condition of reimbursement. A lot of emphasis behind it. We need to step back and ask, well, what is the problem with shared decision-making is the solution? So candidates that have been offered in the literature as a way of correcting paternalistic behaviour in medicine, dealing with issues of evidence uncertainty, practice variation, unclear information, uncaring interpersonal communication. The thing is, patients don't suffer from these things. Patients don't come to our healthcare organisations because they're suffering from uncaring interpersonal communication or evidence uncertainty. They come to our clinics, to our offices, because they have something wrong in their lives. And the reason that they're going to make decisions with their doctors or their healthcare professionals is to advance this problem and come up with a plan of action that makes sense to them. So I'm going to argue that the purpose of shared decision making, like all medical decision making, is to advance patient problems. And that we make decisions in order to act well, not to decide. Which means that we can think about shared decision making in very simple terms, being a conversation. It's made necessary by a problem in which patients and clinicians together figure out what to do. Now the rub is that there's many human problems, which means that we need many methods of responding to them. So, for example, we don't use methods of amputation when somebody has a cold. It's just the wrong method. It's actually methods for the problem at hand. A little extreme. So how do we think about methods that are required in shared decision making? To me, this suggests that we need to move beyond methods of involving patients in choice to methods of together with patients addressing their problems. So to talk through a range of kinds of problems and kinds of methods of shared decision making, I want to share a little bit of the story of a made-up patient called Rachel. Rachel is a 26-year-old woman. She, in this vignette, is talking with her primary care clinician. She's looking to find a new method of birth control because she's dissatisfied with her current approach. So the primary care clinician and her together sit down. They talk about the different options, the way the pros and cons of each of them, and together they come to a decision. This is very much employing a method of weighing pros and cons to try and find on balance which is the best approach. Now, in the second slide, we see Rachel and her partner decided to start a family 3 years later. And in the third trimester of pregnancy, Rachel was talking with her obstetrician about how she would like to give birth. Now, Rachel comes from a part of the world where 90% of births are via C-section. But in her new country, she's considering vaginal birth. She's sort of internally conflicted as to how she wants to proceed. Now, the decision here isn't going to hinge on pros and cons of the different ways of giving birth. The decision is really going to hinge on how Rachel can resolve the inner conflict find what's right for her based out of a clear understanding of what it is she wants. So an approach of negotiating conflicting desires may well be an appropriate way for a clinician to help Rachel make this decision. In this third slide, after birth, unfortunately, Rachel is admitted to the ICU for sepsis. And in this case, Rachel, her family, her clinicians are gathering together to try and figure out how to manage the situation. There's a lot happening medically, but there's a lot happening from the family side. Issues like who and how should we care for the breastfed baby? Who should spend time with Rachel? How's the family going to rotate? How is the clinician trying to support her through this experience? So here, a method of problem solving with Rachel and her family may well be the right way of coming to a good decision. And finally, and unfortunately, this slide, you see Rachel in the ICU, unresponsive, on life support, and Rachel's husband and her parents are arguing about what it is that Rachel wants, how the baby should be cared for, and what it is she should do. And in this instance, the decision isn't likely to be made by weighing the pros and cons of different life support methods. It's not exactly a problem-solving issue that's at play either. In order to make a decision here, what might be required is for clinicians to talk with the family and together uncover a deeper sense of what it is that truly matters in this situation. The argument being that if we can grasp what's truly at stake, well, then we'll know the right thing to do. So these are all instances where patients, families, and clinicians are making decisions together. But they're very different situations, requiring answers to very different questions. Which is the best form of birth control? How do we manage care in the ICU? What is it that I want? What truly matters in this situation where we're making a decision? And so, as I say, different situations, and they require different methods, they require different ways of interacting with patients. Each of them pursue different purposes, and I'm going to argue that each of them are different kinds of shared decision making that stretch beyond a method of involving patients in choosing what it is to do. So to quickly summarize these four approaches, we have one that's focused on the alternatives, which of these alternatives is best, and it sort of arises where it's uncertain what the benefits and harms are going to be for a particular patient and how those things balance with their preferences. The second question really focuses on the will of the people who are doing the choosing and agreeing what it is that you want to agree on. And that arises where there's conflict around concerns, interests, and agenda, either between people, maybe the patient and the clinician, or as in Rachel's case, an internal conflict needs to be resolved in order to come to a way forward. The third case is focused on the problematic situation. Something's clearly wrong. What do we do with it? About it is unclear. How do we manage it? So we saw this in the ICU. We also think a lot of this happens in care for patients with multiple chronic conditions, where oftentimes decisions aren't weighing pros and cons, they're really problem solving, figure out how to move forward. Finally, there's the focus on the humanity of the situation. Trying to get at and understanding what is it that really matters. And that happens when the humanity of an individual or a community is compromised or is in some form of existential transition. So that might also include things like the decision to move out of a family home of 40 years into nursing care. There's an existential transition that's happening there, not really a matter necessarily of the pros and cons of being at home in this facility. And perhaps the conversation is harder if you focus on that particular issue. And so the implications of this is not only that there are many methods of making decisions with patients, but if you do use the wrong method at the wrong time for the wrong problem, you can expect issues to arise. So as I say before, using a method of weighing different forms of life support isn't really going to help Rachel's family come to some sort of resolution. What should be done in this horrible situation. So we have lots of factors that are at play, all of these which are themes in shared decision making, but they're not put together in any particular easy way. They have to be found, drawn out, made to work productively together and caring for a particular patient in their particular situation. And so that's really an idea of care that's centered by people and their problems. To contrast with a lot of what we do, which is care that's centered on people and their problems. Centered by, centered on. Now, healthcare has a long history of centering on patients, and Marlene will know this very well. Comes from writing and and we continue to use this sort of image in our healthcare going forward when we talk about putting the patient in the centre so that we can focus our attention on the individual patient. And it has implications for things like how we think about experience or patient experience in healthcare. So patient experience is commonly thought about in the general vernacular, certainly within healthcare institutions, as being the range of interactions patients have with the healthcare system, which is essentially a view of experience of being all things that healthcare does to patients while they're within its walls, physically, digitally, or administratively. There's another way of thinking about experience, and that is the experience of what care joins. It's not the effect of an interaction. Experience is the reason for all of us being in this room. It's not the effect we have of operation. And so, in picking up this theme of care that's centered by patients rather than centered on patients, I was struck by the sculpture, which is located probably within 200 meters of where we're standing here now, as near as possible. And what I particularly like about this image is that big brick building is right in the middle of the circle. And the only reason that brick building is there is because of the people that it serves. So for me, it's an image that turns us toward the idea of how do we draw out, establish, and create healthcare so that it's centered by the people that we're serving rather than centered on. I'm going to draw it to a close. Happy to take any questions you have. Anything I can help anybody with, or I'm very happy to chat over the yay coffee.
Yay coffee. We're just calling it yay coffee.
please.
Can you clarify the difference on being centered by and centered on? I'm not sure I get the distinction.
Sure. I think it's fairly subtle distinction, but we think a lot about how we put the patient at the center. For example, and that's a lot of us doing the pudding. So we have all the stuff, how do we put it on people, how do we organize, how do we coordinate in such a way that it's effective. And there's a lot of good reasons for doing that, operationally, ethically, and the like. But I'm suggesting that there's a difference between finding the care as something that's created out of an ability to be centered by with this person. So who am I as a person in the presence of this patient, for example? And when we combine that, then I'm centered by this person. I'm not solely centered on this person, bringing my expertise beyond.
I wonder, I'm from New Zealand and we have a saying that might help clarify, particularly for our Indigenous population, and it sort of goes along the lines of they've consistently been asked to the dinner and not the menu planning. So if care is centred by the people that you're working with, they are co-designing the services. Is that what you were?
Yeah, that's certainly in the spirit, that how do we draw out a potential based on who we're dealing with, rather than how we apply our skills to them. And welcome, I'm from Timaru, so I'm very happy that.
Can you repeat when somebody, can you repeat the question?
Okay.
That is,
Okay, that's a very good.
Thank you for your talk, I really enjoyed it. Can you just comment on how kind of preventative medicine fits into this model? Because when we're thinking about preventative medicine, the patient may not have a problem.
Yes. Yes, so the question is, how does preventative medicine fit into this moral or shared decision making? And that's a very good question, and one that we struggle with, because as you say, nobody particularly feels hypertension. And so it's a challenge, as I'm sure you're aware, of how to treat issues such as that. And so the way I think it manifests here is that in some ways it's not really treatable until we have some sense of experience around it. So it turns from being a risk to experience when we move from the idea of risk to threat, for example. So threat is something that we experience, a risk is not something that we experience.
I think bringing that the emotion that threat evokes versus a risk.
Yes, yes. A threat is a good reason to act. A draft is not necessarily.
Other question, verification, or thoughts, preference.
I have a question which I think is probably difficult to answer, but maybe you can provide a solution. So sometimes in healthcare systems, I think there's a recognition of having care centered by the patient.
Yeah.
So in our hospitals now, there's a little sign that goes behind the patient, and it talks about what's important to them, and it's meant to be at the top of their bed. But I find when I sometimes go into hospitals to visit friends and relatives that either it's not completed, or it's pretty much ignored, or it's completed with things that I think are overly simplistic.
Yes.
I just wondered how, for instance, here at the Mayo, we maybe have moved from tokenistic efforts or acknowledging things to transforming it to real kind of emotional change in the way people are looking at things.
Sure. So you're right. That is so the question was, how do we move away from tokenistic depictions of who people are and what matters to them, and move perhaps more to this idea of how care can be centered by the person that we're caring for. So Mike Wilson, who will be talking with us at some point, has done a lot of work in this area in the ICU. But I share your concern too that a lot of these representations are simplistic, very light images of this person. And so in some ways that oddly turns back to the ICANN decision making, my healthcare tool, which as I said is really trying to get a sense of is there something here? And so any value that I see in that is as a point of provocation. Is there anything here? Now, clearly there's something there, but it doesn't have any life until we animate it with our questions, our concerns, our willingness to engage, to expand on what is this photo, or what does this mean that I like this TV show or whatever.
And I think Sarah McCarthy's workshop on SDM and pediatrics, that's one of the things that she's grappled with also in making pediatric patients' wishes and personalities known as part of the longitudinal care process. And so she also would be a great person to bring on some of the work that she's done in that area.
Ian, in the beginning,
yes.
shared decision making was portrayed by I'm going to be very, very coarse in this history, but in the beginning, nurses in Canada thought we should arm patients with knowledge so that when they go to, these are not the nurses in Canada, when patients go with this knowledge to the consultation, they can match the power of the clinician and wrestle from the care that is appropriate for them. People from Dartmouth in the New England area here thought, no, we're going to arm patients with knowledge so they can deal with the problem of supply-induced demand that leads women to walk away without their uterus just because somebody with the ability to take their uterus out has moved into town and is doing a lot of operations. And so it was a power, it was arming patients to go to war. In the second phase, people imagine a collaboration, a co-creation, the idea of patients and clinicians truly sharing, right, and just informing the patient, truly sharing the decision. And a lot of the work that we have done here was sort of embedded into that second phase of less war and more collaboration. You seem to be suggesting there's a third phase coming up, one focused on identifying the purpose, identifying the problem, and centering by the people involved in the problem. Is that an over read on your suggestion, or is this a refinement of the second phase, or are we moving into a third phase of shared decision?
So I think it's a yes and the way I would come at it is to sort of flip that progression around. So as you say, we had issues of power turning to issues of collaboration. This is turning to issues of problems and our ability to respond to them. And if we start from shared decision making being a means of making decisions that allow us to act well in the best interests of the patient, well, that requires ways of working together in order to make that happen, the collaborative emphasis, what you call the second phase. And for that collaborative effort to work, we need to overcome any power issues, power imbalances that inhibit that collaboration from happening. But where I'm coming from is saying, well, let's start with the problem, what's required to address the problems, then move into what are the relationships between people that allow that to happen.
I wonder, adding on to that, the concept of that third phase is about an identity shift that has to occur in clinicians as no longer being the experts who can impart their wisdom, but instead a sense of discovery along with patients, which is a very different identity than is it like practitioners are trained in when the system creates. And so how do you, by targeting identity versus targeting behaviors,
yes.
Behaviors are tokenistic, identity is not.
Yeah, so we're going to take that question up. So issues of identity are a big challenge in healthcare at the moment, and Victor's will be able to help us understand that through the idea of industrial healthcare, where clinicians are providers, dropping buckets of care on people. But I think there is a core of clinician identity, the idea that we're in this to help people and to care. And so a sense of identity, a sense of character, a sense of discipline emerges out of the actual work of caring for people. Now that is a different view of identity to saying, I'm person X, I have great interpersonal skills which I'm going to apply as a true manifestation of who I am as a person. Both of them need to work together, but the third approach suggests that clinician character comes out of the work of caring.
I'm interested in thinking about the movement from to centering by rather than centering on. It does suggest a different, slightly more active role for patients. And I'm curious what thoughts you've had about what sort of sharing, engaging skills, resources, sort of support might help patients be able to take on that role or feel more comfortable in playing that part, or what you maybe have been thinking about as research.
Sure. So in some ways, this gets back to Victor's question of empowering patients in terms of the ability to counter the excesses and evils of clinicians or providers. So the idea of centering by, it's really a matter of how do we draw out the potential of one another. So how do we help patients draw out the potential of these very skilled people in order to help them serve them? At the same time, clinicians are in the role of drawing out the potential of patients to contribute to the resolution of the situation that they're in. Please.
One of the problems is also continuity of care with patients. And I've looked after patients like this in the 1980s in the NHS in the UK.
Yeah.
No problem, because I walked in on the same carpet. I saw her in that environment. And I work in Melbourne, where I hardly ever see patients in this environment. We have no currency, we have no common language, we have no common understanding of what our problems are. And no matter what wonderful interpersonal skills I may have,
Yes.
it's not going to mean anything to her when I don't know her.
Yeah, no, exactly. And so we have this sort of divorce between people and the kind of situations that we're caring for. So one way we can play about thinking about that is whose problem is it anyway? And the sort of divorce model is that you have a problem over there, which you're going to bring into the clinic, and I think you do my best to decipher. Maria Luisa has a problem here in her life, and the question really is, how do you share that problem? Or how do you tackle it? And I agree that continuity is a big issue. And that's one of the challenges we're seeing in shared decision making too, is that as a solution at one point in time to do A or B doesn't necessarily have much continuity with what came before, what's going to come after. Summer.
So last part, I know piece the last question. I think, you can maybe allude to this with the group. I think the conversation is phenomenal, and we're talking a lot about how to center this with patients and the role of clinicians. I think the aspect that I did want to get lost is also the industrialized part, to Victor's point, and the system part that drives a lot of this. There's very much a negative connotation a lot of times now toward clinicians in the healthcare team of what they're expecting of patients, they're not centering the. There's also a realistic aspect of how people's jobs and expectations are being set. As an example, I just got my review that I'll get every 6 months, and one of the things that I'm held accountable to now is my diabetic panel and their role. So it's now it has nothing to do with actually caring and centering on the patient, its numbers and its scores, but that could potentially probably not realistically here. In other places could negatively impact my job and my function. That industrializing part of what pushes people is really unfortunate because it directly impacts their ability to care and to share in that function. So I just think, again, ways that we can all work together to make that stuff change, because it's not centered on the patients. Giving me a D5 score, because I've been able to tell for the last several years my diabetic patients and what their challenges are, and we just don't change the system to support them. So again, I just think, again, to that conversation, we're not forgetting that part of really impacting that relationship and impacting that interaction.
Yes, no, exactly. And I think that's a symptom of what you're doing with patients is you're helping them with diabetes as an this in their life, which may or may not have much to do with their hemoglobin A1C. So how do we turn back to that when, as you say, the system is moving in some ways back to phase 2 and phase 1, which is how do we separate people? How do we make sure not only that patients have the power to counter clinicians, but how do clinicians have the power to counter the bad behaviors of their patients?
Okay, so amazing discussion. We can continue it at this day caffeine break. And the caffeination breaks are 30 minutes, which is an extended